Oh, there you are.
Hey, everybody. Welcome to our virtual class session on precepting and critical care. I'm Krista Rachinsky, and I'm here with Jeanette Rack
Hi, it's Jeanette again.
and Allie Martin.
Hey, it's Allie.
And this class session is going to be talking about some cool stuff that we will cover in more depth when we are in person, but we want to get into it and start with reviewing our roles of the preceptor. I know that this has been covered in some of our previous sessions, but just to remind you, wow, there's a lot to do as a preceptor. So that clinician, role model, leader, communicator, socializer, educator, evaluator, and protector, all of those things we're going to touch on today. So just to refresh, and in the model that we've been discussing for precepting here in critical care at Kaiser Sunnyside, married state means we are right next to each other. I'm showing you things. We're talking through process together. And we always want to keep it in context of that lens of the Benner novice to expert continuum, and that we're always growing and changing, hopefully, right? Moving, progressing along. And if there's a problem or a snag in the process, as preceptors, we want to step in and maybe dig a little deeper and assess what's going on there. Do we have a knowledge barrier? Do we not have the right opportunities? Do we have an information gap? What's going on? And just from an evidence standpoint, I will tell you the biggest problem that we usually encounter with a clinical practice deficit is knowledge deficit. It's because people just didn't know. So as the preceptor right there with your intern, just know that, be generous with your assumptions, assume good intent always, and just know that it's probably because they didn't know how to ask. And then we have been talking about something that's kind of new. It's called tiered skills acquisition model. And this model of precepting is just talking about how you move somebody through that novice to expert continuum in a way that helps them progress and become independent by the time they reach that competent stage. This is for review. We all are familiar with the Patricia Benner continuum. And we've also talked in previous class sessions about the nervousness that comes with being an expert in your old clinical setting and then coming to a new clinical setting and being all the way back at the starting line. It's hard to be new, so please be compassionate and have some grace for those folks as they enter this new continuum. All right, a little bit on the married state here. This is a nice graphic that Allie found, and it really calls out these phases of how to guide that intern through the married state preceptor model. Phase 1, be side by side, be right next to them. Stage 2, have them shadow. And then number 3, put them more at the front line. And then 4, hopefully they're moving through to that competent state, that competent practitioner. Allie, share a little bit about other things that you appreciate about this graphic here.
So I think when I found this, it just kind of made it all come together. I don't know why the term married state just is a strange, I don't know, it just doesn't really make a ton of sense to me. And then I saw this and I was like, oh, this kind of brings it all together on, you're always doing stuff together, and especially at the beginning when you're in that novice state. And then I even say shadowing could be you shadowing them, and then or them shadowing you, but also you shadowing them, and then moving to that front line where they're kind of the point person, but then you're always still available. And I watched a little video, and it was basically because I tend to, towards the end of a preceptor or internship, let them take the reins more, but also making sure that your patients know that somebody else is there. So at the beginning of shift, when you do handoffs, saying, hey, having them introduce themselves and then either introduce you like, hey, I'm new to the unit, I'm precepting, this is Allie, or hey, this is so-and-so, I'm Allie, I'm going to be the preceptor. They're taking the reins, they're in control, but I'm here. You might see me in the room. But I'm just here to answer any questions and to facilitate this. But if you need anything, you're more than welcome to, let me know. So that way both parties kind of feel safe. I think that's another thing. And also kind of to give the patients that awareness as well. That something that when I was looking at this, maybe towards the end, am not always as mindful of kind of, letting your patients know as well that what's going on, so that you don't, everyone's always safe, I think is the key thing. but
Mm-hmm.
also giving them that space to be the competent practitioner and letting them go when it's ready.
Yeah,
Um,
totally.
and but always knowing that you're always there for each other and you're always there. You're never gonna let you're never, as a preceptor, you can never basically always have to ensure safety. You're never gonna let them kill anybody.
That's right. You're always safe. I think about managing up. That's a term that was probably just an old organizational term for me, but I'm there at the bedside. We're, doing shift report and I'm introducing myself to the patient. And I introduce that intern and I manage them up in that moment. And I'm genuinely saying, hey, this is Allie. She's a great nurse. She's gonna be working with us today. You might hear us going through some of these things out loud. We're just gonna be talking about a lot of our processes. She's not a new nurse, she's just new to our unit. So we're going to be working together. So, let us know if you need to interrupt us for anything, but expect that, you lay the groundwork with the patient. Expect us to be talking about things. And if you need some quiet, we can go talk out in the hallway. So let us know, what we can do to help you today.
I think that's my favorite thing to say. And I do it a lot. I'm really good at it at the beginning. I just, towards that frontline competent practitioner part is maybe when I tend to phase out a little bit more because I'm giving them that autonomy. And I think maybe continuing it through that end piece is something maybe we don't do as much. Maybe it's just me. I don't know. But I really like the phrase of they're not a new nurse. They're just new to the unit, opposed to
Mhm.
saying they're an orientee or they're an intern. I just feel like it not that there's anything wrong with that, but it almost diminishes their value in a way in front of the patient, and making sure you acknowledge the fact that they're not they're not a new nurse. They know what they're doing. They have a license. So I think that's important as well.
Absolutely. Jeanette, what do you like to do in this? Do you have any little pearls of wisdom?
I mean, I think that is usually the best like introduction to the patient. So that, and I also kind of like to say, you might hear us talking about things in medical terminology, but this also can be for your education as a patient. So, I'll be teaching sometimes in the room. And if there's anything that you hear that you have more questions about, please feel free to interject. But just so that you understand, we're trying to um, like what we're trying to do here with
Yeah.
our intern.
Yeah, and you invite them into it.
Yeah.
So you do a little intro and you invite them into that moment. That's really cool. I like that. And the highlights are this person is great and we invite you into our conversation. Let us know what we can do. All right, so we already talked about this, but I wanted to put it up here for review and reference, and we'll dig into it more in the in-person class sessions. But again, just moving through that expert or novice to expert continuum and letting them take the reins, using that phase 3, that front line. I'm going to put them more up there as we get to the higher pieces of this continuum so that they can get the correct experience and they can have that confidence building, because what this model called out there, you can see in the text, is that nurses that are new to a certain practice area, they showed in the literature that they wanted a little bit more autonomy earlier on in their experience. And historically, that's where we've gone wrong as preceptors, is that we think, oh no, you're not ready for that yet, I'm going to hold on to you, and I'm going to have you watch me do it a few more times. And really just to be more open to changing your preceptor mindset and say, hey, you watched me do one, we've talked through the skills checklist, what do you think about doing this one on your own this time? Or I'm going to be right here. So really going back to that, I like the phases here, how it kind of simplifies, putting them in that frontline phase 3, maybe a little bit sooner than you have in the past, and just talking to them about it. How do you feel about it? You feel comfortable doing it? And I'm going to be right here with you. So, if it's not okay, we have a little cue word that we worked out ahead of time. I'll just step in. Okay. Well, you guys know that being a preceptor has a lot of components, and we've certainly talked about that leadership role a little bit. And I just wanted to offer one of the tools that has really encouraged me over the last few years, the book Dare to Lead. Allie, you mentioned you're reading it now.
Yep.
There's some downloadable resources on the website, breneebrown.com. There's the Daring Way, which is a whole leadership development group. There's a lot of resources with this, but I like her work and the way she explains things. It's the right translation for my brain. And specifically the Daring Leadership, or the Daring Greatly Leadership Manifesto that you see here. Just that description right at the top that says, hey, as a leader, you are someone who holds yourself accountable to finding the potential in the people and the processes that you're engaging with. And so there's a lot of good stuff in this, and it's cute and decorative. It's hanging in my office, but this is some of the stuff that helps feed my soul as a preceptor and a leader. What do you guys think? Anything that helps fill your bucket on this stuff?
I don't know. I think it just kind of also, it's not about, once again, it's not about being right. It's about doing it right, and that you do want to inspire others, and you want, but to do that, I kind of like it all. You have to be vulnerable and courageous. It's not easy to, this isn't the easy route to take,
Yeah.
but it's, it helps us grow as people, and as a unit too, if we're going to apply it to nursing in general. So I don't know. I really like her work. Thank you for
Jeanette?
introducing me to her.
Oh yeah, totally. Jeanette, what are you thinking?
I think a big part of this is how leadership also depends on the person that you're leading. I think it's about the relationship, and it's hard to lead somebody who's not engaged back with you. And I think for me personally, I often find that I'm a better instructor, I'm a better leader, it's kind of like you feed off of each other's energy. And so if you have an intern who's like bringing that to the table and is like excited and asking questions, it's really easy to like lead that person. And that makes it fun and exciting. And so when you have somebody who's not as engaged, or maybe has having trouble being there, is just like in a shock phase, that's when you really have to like dig deep and kind of try to find other people to help encourage, and like either help reinforce your leadership skills, or I find that's kind of interesting about this manifesto.
Yeah, Allie, you got something else.
Oh, I was just going to say, I will say finding somebody else to help you with your own. So I find that if it's not going right in a internship or a preceptorship, I always end up thinking like, what am I doing wrong? Like, how am I not helping this? What can I do differently? And, sometimes that means, leaning on Kristen, or asking your fellow, your other preceptors or your charge nurse or whatever that may be. But, a lot of times it's not, you've put everything into it, and you can only get out of it what the other person wants. And I think this kind of falls back to our first lesson, where when it's great, it's great. When it's bad, it's not fun. But I think that also helps you grow overall as a preceptor and as a nurse and a person. Just like, what could I have done differently? And you ask those same questions, which we'll get to in a minute, on how we invoke critical thinking. I think I use those same questions in like, how can I be a better preceptor as well? So, all right.
Well, I just want to say one more thing about this work, is that I think I've read this book at least 3.5 times, and I've used the workbook, and I've used some of the tools that are available on her website just to do more of my own work. I know I've become a better leader professionally because of this work, and I think that it's also made me a better mom and a spouse and a sister and a daughter, because it's given me tools to deal with when I'm stuck, when I'm frustrated, and how to gauge expectations. And that if I'm disappointed consistently, well, it's because we're not clear on the expectations. Somebody is disappointing somebody else all the time. And so, we all have our origin story of work to do. And just acknowledging that, man, I didn't come into the professional workforce with a lot of the language tools on how to set boundaries, or how to, whatever the issues are that we all come with, doing work like this. And there's so many other helpful tools, but this has just been something that really has helped me develop and grow. And I encourage you to lean into whatever is really feeding your soul and speaking to you, and helping you grow and stretch you a little bit. And there's a couple verbs on this manifesto that, when we talk about feedback, is a function of respect, and to be generous with your assumptions, and to dare greatly, which means like, hey, if you are brave and you live in a big space and you take the risks that it takes to do this work and to be your fullest self, bring that to the world every day, that you're going to fail. It's not if, it's when. And so as you do, to be okay with that and then learn how to pick back up. And, certainly in being a new nurse in an arena and being a preceptor, we have to deal with a good share of, okay, that did not go well. Let's regroup. Let's figure out how to get this right. And so this just helps us stay in a psychologically safe environment, and how it gives us tools on how to create that for somebody else. Okay, good stuff. Well, talking about learning and growing, a big part of that is critical thinking. And so we've had a few conversations, and we'll have many more about this, but as preceptors, we want to encourage you to use these key pieces of conversation and organizing for a patient assignment to guide your intern through processes of critical thinking and have conversations. So sometimes it feels like you got to just pull it out of them, and they don't know what to say, or they don't want to say the wrong thing, or they don't want to be wrong. They have a fear of being wrong, or whatever it is. And so you make it psychologically safe, and then you can move into this stuff. And this is really where a lot of the value is, especially in critical care. So you have to jump from this one side of the cliff that's just, I know all this stuff. I read it in a book. I took a whatever class, and then I have to apply it, which means I have to synthesize, integrate, apply, integrate, evaluate, all the words. How do we do that, you guys?
Sorry, Kristen, what are you asking? How do we, I'm waiting for the next slide because that's my favorite slide.
Oh, okay. Well, you know what?
And I think that's how you do it.
Let's get to it. Let's get to it. Go. I know both you have a lot to say about this. So how do you do all that stuff and get them to think critically? You do these things.
Well, Allie found this slide, so she gets the credit for this, but I'm obsessed with it. I love it. And I wish we had it a long time ago.
Jeanette, while you're on it though, do you want to call out the favorite pieces that you really use?
Well, to be honest, I mean, I haven't used this because Allie just introduced this in our discussions. And I think I do use some of these things without really acknowledging like how to pull out critical thinking. I think some interns are really good at just like putting critical thinking forward and kind of going through their thought processes, and others you sort of have to elicit these questions out of. And this template just gives you a really great identification for which like ways to elicit these conversations.
Yeah. Allie?
I think that's kind of where, when I was looking for something that was helpful for this, this series that we're doing, to me, I find that first of all, how do we measure critical thinking? Like it sometimes can be subjective in a way, and everything that we need to measure, it needs to be objective. And so sometimes it's like, well, they're just not critically thinking. And it's like, well, what does that mean? And how do you explain that to, whoever it is, like for help? So I found these questions to be a little more helpful as far as like, how do we get there? So that's kind of, in my research, that's kind of where I found these. And I think having these questions makes it a little more measurable, but then also gives, gives us just ways to segue into that as a resource for preceptors. When you kind of feel stuck, you can maybe refer back to these. Like, I feel like we're not getting anywhere. It's like, what can I do? Oh, let's maybe start back to this, like, and go through these questions to kind of help us get to where we need to be. So,
yeah, totally. Jeanette, what do you think?
Oh man, I think the thought just,
I hate it when that happens.
it just escapes me.
It happens to me all the time. Can I just share one thing while you're thinking of it?
Yeah, go for it.
What I love these questions. So essentially, if you're not somebody that is used to having like this, slings from the hip question, pull this stuff out of people, because this actually is really hard, even though it's like, oh, these are some nice questions. Let's talk about like, what do you need to know? How much risk for error and how much time and all these things. When everything is patient-centered context, right? And so something that I always use is, where are we in the story? we have a patient in front of us. We have a patient assignment in front of us. Who's the priority? Why is that the case? What are the considerations? Who are the players? What is the time constraints? But where are we in the story? And that helps us prioritize our next actions and then say, okay, of those next actions, what has to happen like right now? And what has to happen in the next 5 hours? So where are we in the story? Those are the natural scripting tools that I've learned, because that's just what flies out of my mouth. Jeanette, did you think of what you were mulling on?
I did. So a few recording sessions back, we kind of talked about the intern who is mimicking and kind of trying to call out, like, are they doing this because this is in our standards of care? Are they doing this because this is how a nurse showed them to do it? Are they really understanding what we're looking for? And so trying to see if, are they just going through the motions, or do they really understand what they're doing and why, and the purpose behind it. I think one thing that I often call out is saying, we talk about prioritizing care a lot in nursing. And I find that in the critical thinking or in the critical care units, prioritizing care is definitely something that comes into play in a minute by minute basis. If a doctor asks you to give blood, draw labs, give this medication, and help set up for a line, those are things that the doctor wants done in the hour. And there are certain things that you need to do before something else. And maybe the doctor doesn't always say, do this first, do this second. And so questions like these saying like, okay, what's influencing your thinking, and why do you want to do that before? Why do you want to draw labs before giving blood? Or maybe why do you want to give the blood and wait to draw labs? That's a really generic, simple example, but I find this set of questions I'm so excited to use in the next set of interns. And just like maybe even we need to make it a badge buddy, because I think it's phenomenal.
They're helpful. And also in that middle block of how much time do we have, we also probably need to include how much time will that take? Because setting up a line and placing a line or whatever that procedure, if it's a bedside procedure, how long do I need to carve out in our day to give to that procedure, that assignment, that task? And then how do I prioritize everything else around it? Yeah, lots of good stuff. We're going to have so much fun in the in-person classes, you guys, I swear. All right, I got to load all these up here because they were cute and they're animated. But essentially what we want to talk about here, oh boy, it's so much good stuff. Jeanette, you found this good stuff. You want to share a little bit about it?
Yeah, I have a lot of flashbacks to my own internship coming through the ICU, and I just remember vividly not feeling like myself in the first couple weeks, in the first month probably. It was so much to learn. I was coming from 3 South, which is a medical unit. I had never really had any ICU experience, even in my college courses. And so like experience to ventilators and art lines and vamps, like everything felt new and exciting. And really what it did is it pushed my personality aside, and I kind of became this like business oriented, very focused. And the thing that stands out to me here is the recovery phase of like the return of your sense of humor. I remember just like thinking in my mind, like, I'm funny and I think I have a pretty great sense of humor, and I just couldn't find it in the beginning, and I felt so unlike myself. And I try to remember that with interns now. Like a lot of times they are not the person that they are in a day-to-day life. They just are processing so much new information. And so I really found this honeymoon shock recovery resolution side very applicable to my experience coming through the internship. And I think it's just a good, an intern could go through this on a 12-hour shift. They can come in feeling like really energized, want to learn something, feeling like everything is great. And then maybe their patient goes south and all the information becomes really overwhelming. They're frustrated. They can't feel like they're in the weeds. And then they eat a little bit of lunch, they come back from their lunch and their patient is stabilized and they're joking and feeling great. And then the end of the shift, they're like, forget this, I'm done. I don't ever want to come back.
Oh God.
I think you could see this in a 12-hour phase. And then you can see this over the course of 3 months. So it's just important to kind of remember when you see those big swings in personality or big swings in engagement, what that intern is going through.
Yeah, totally. And just like we have the continuum for learning, this is their journey. And these are the steps that are along their journey. And as preceptors, we do have the opportunity to, to one, be aware of what we're seeing. Hey, it looks like things are going great. Or, oh, I don't know, they seem really nervous still, or they seem frustrated. And that, we have this section in each of these that says, hey, preceptor intervention. Say, hey, can we offer them something? Can we offer them just, a time for them to vent, or maybe a connection to a mentor, or maybe a little, I don't want to say care conference, but it's a conference about them. Hey, how are you doing in this process? And then specifically, I think these first two, the honeymoon and shock, are really obvious because, well, you know what it looks like when you feel like this. Everything's all right. And you know what it looks like when you feel like this, like you just been, traumatized. I think the recovery and the resolution are things that I know it took me some time to really get my head around. Allie, you've worked a lot with this.
Yeah, I think it just takes time to kind of recognize it overall and kind of where you are. And just like Jeanette was saying, it can happen over the course of the, time of internship or preceptorship. But it can also happen day to day. And realizing it, kind of what you need to do as a preceptor, I think is the part where you might recognize it in them, but then in that moment, because it might not be for very long, but it could be fairly critical of like, how can I intervene? What do you need from me? What can I do for you? I think that also, sometimes you're not going to get a response. And I think that's when it's harder, because they might not know what they need. But also being available for that. And I just think it takes time and practice and you know, just like no one's perfect. We're human and you might not always say the right things, but just trying to be available and present, I think is huge, and trying to kind of just build that relationship. And then having trust with you at the beginning. They'll know that during that shock phase that you're not going to let them down and you're going to be available for them, I think is huge. And then the resolution phase, where Jeanette was saying, I'm not coming back. I think, you feel that way sometimes, but I think sometimes people might not want to come back and they might realize that it's not a good fit for them. And I only say that because it's happened on our unit that someone realized, like, I don't want to be a PCU nurse. This isn't what I want to do, which is okay. We want you to be where you want to be. For selfish reasons of, I don't want to invest my time and energy into something that you don't want, but then also because I want you to be happy in your career and your nursing and your work-life balance, your nursing life, like that's what's going to be best for you and best for our patients. So I think, making that, if you see that coming up over and over, I know for me, it was like this awkward conversation, like, hey, if you don't want to do this, like no one's going to judge you. You wouldn't have known unless you tried. And it almost feels like I'm saying, well, you can leave now, which is not what it is at all. But that's almost what it felt like, because it was the first time I'd ever said that to anybody. But it kept coming up, like, maybe they don't really want to do that. Like, maybe you don't want to be here. Like, and that's okay. And it wasn't a bad thing. And it ended up working out really well, for that person, because they realized, hey, I tried it. I did it. I'm not a failure. There's nothing in it to be judged about. Like, I just liked what I did before, which is totally reasonable. So
yeah, totally.
A little bit different perspective on it that I had just within the last year and a half, I'd say came across, that I had never come across in a precepting environment before.
Yeah, Jeanette, go ahead.
I think also giving a warning that like you are going to feel like you're in the weeds. I think a lot of people have probably been in some sort of service industry where you feel like you're juggling many balls at once and you don't really know which to prioritize. And I think the idea of saying, listen, you're going to have to feel this in order to get to the recovery and resolution field. You're going to have to feel uncomfortable. You're going to have to feel like you don't know what to do first. I'm here to be your safety net, but I can't save you from the feeling of shock. It's going to happen. It's going to happen multiple times. And you just have to find, and it's going to happen throughout the rest of your career. There's going to be days where you just feel like I can't manage this. And that's why you have a charge nurse and people to help you. And it
Yes.
just feels worse when you're in an internship.
And when you don't know that it's going to end. I think what you just said is super valuable in that you give them your perspective. You let them borrow the lens in that you see the world, and you say, hey, the part of that recovery is, can I give you my perspective? Can we zoom in and only see angry bees coming at us? Or can we zoom out and see that sweet honey pot to know, hey, this is going to pass, you know?
And we learn from it.
Totally.
I think
Absolutely.
that's when it becomes a learning moment. You help and you intervene in the moment, and then you reflect on it again, and you learn from it, and then you only grow, both you, the preceptor and the orientee. So
Yeah, and we're definitely going to be digging into this scripting tools and recognition in the in-person class. One of the last sections that we want to cover, it's just such a fun little topic of the legal lens of our practice. I wanted to offer you some structure and guidance and resources on how to learn more and what to be reminded about as a licensed person. So in general, obviously we're practicing in the state of Oregon. So the Oregon State Board of Nursing is the governing body that gives us our registered nurse license, and they also are deemed to be the rule setters by the state, that makes the laws. OSBN makes the rules. So that's why we see Oregon Administrative Rule, or OAR, and then a big fat number by it. So scope and practice standards for all licensed nurses. This is just a refresher for all of you. We all need to know, what are the laws, rules, and standards that we are legally held to? And then how do we build our nursing practice of safety and good habits that help us be that cohesive nursing practice? So these are sort of the tiers of structure that I would want you to know, or reporting structure. So we have the Oregon Nurse Practice Act, that's that top one there. And then they decide the scope and practice standards. And so these are available on their public domain. They're always very easily discoverable with a quick Google search. So just to refresh you, and we'll provide some of that reference information. And then what are the organizational policies that we're held to? Because those are also that legal edge of our practice. And then competency, that's a big component of it. And all of that together makes up our nursing practice. So we're just going to talk overview of these things, and then we can get into more of them when we are in person. So this is what the website looks like when you go to look at what the Oregon Nurse Practice Act is. Do not be dissuaded by any of the fancy chapter rules and OARs and things like that. Read through this. It is a legal document, and so it does have that legalese type vernacular, but just read through it and take a couple passes and see what comes at you. Up here at the header, it says the Oregon State Board of Nursing protects the public by regulating nursing education, licensure, and practice. And so in our standards and scope of practice, you'll find for the registered nurse, this is actually at the very top. So this is Oregon Administrative Rule 851-045-0040. So scope and practice standards for all of us is that we self-regulate our practice, that we know the laws and the rules that govern the knowing and the doing, right? The cognitive and the technical aspects of our nursing interventions and procedures and practice and performance, that we really engage ourselves as professionals that dig into, what are the organizational policies? How am I feeling, that competency, good in the gut feeling that you often hear me say about placing this line, about doing this bedside procedure. We have to really get in the weeds and engage about what is our clinical comfort, and then where do we go from there? After you have a score on it, if you will, I feel safe, I don't feel safe. Okay, what's the next step? Where do we go from there? So it's really kind of getting into the weeds about that. And a lot of this is just dialogue that we'll have in the class, but I just wanted to show it to you. And then at the organizational level, many of you know this, these are our standards of care. So this is the minimum standard that we are held to in critical care, and each care area has their own. So I encourage you to just know that this is legally the lens of our practice that we always want to consider, and to know where to find these things, and we will help you always know how to access them. You guys want to offer anything about legalese? I'm all about it. I have a healthy fear for a good legal lens in my practice.
I do sit on the ethics council. So, I mean, I can go into deep dive. It's like a kind of the border of legalese. It kind of enters into the ethics council.
Mm-hmm.
So maybe we can go into that more in the in-person class.
Yeah, let's do it. Well, we don't have very much time left, but I do want to wrap it all up with everything does come back to the nursing process. So yes, there's the legal lens of our practice and all the things that guide and inform us, but we should feel really comfortable with, okay, we got to start by assessing. That's the first step to every situation is what's going on here? What's the problem to solve? And then, okay, now that I kind of know it, we put a diagnosis on it, a nursing diagnosis. You know, this is the human condition in front of us, and to really lean into that nursing diagnosis, to not let it just be the DRG code or the admission, you know, oh, they're admitted for these reasons. Yeah, but there's a lot more to it. And as nurses, we bring a lot more to it. So we'll talk more about leaning into that. And then, of course, the planning, implementation, evaluation, all the stuff we know. We'll get into it in the in-person classes, but I know this was a lot to digest, but I want to thank you guys for watching this virtual class session and for signing up for the in-person sessions. We have a supplement guide that you can use to watch these videos with and go along with us and engage with the material and references. So any final thoughts, ladies? No?
No, thanks for joining, and we'll see you in the in-person class.
Yes, I like it. All right. Well, thanks, guys, and we will see you soon.